Good evening, Mova. Good evening. A very good evening, my dear NORCET aspirants and my soulful subscribers of Plan C Plus English Edition. So, as a part of our Plan C Plus Platinum English Edition, we are coming up with regular Wednesday and Friday live sessions. Right? So, this is our Friday live session for our NORCET. And we will wait for 5 more minutes to people to join. Yes, very good evening Priya, very good evening Kaushik, very good evening Poonam. Kab launch hoga? This is launched before 2-3 months. Okay, this pack is purely on English language so that you, the South Indian audience will not have any language barriers to study for your NORCET examinations. Okay. So, as I said you, these sessions, basically the Wednesday and Friday sessions, they are majorly focusing on high yield topics and followed by the high yield MCQ discussion. So, today also I have come up with an important topic which is related to your cardiology. And now I just want you people to guess the topic, like it is a pharmacology topic. And today's topic is anti-arrhythmics. Now just tell me whether this particular topic is important for your nursing competitive examination or not. Yes, obviously many questions come from adenosine, digoxin, amiodarone, like what is the side effects, what is their action, what is their dosage. So many questions come from these particular topic, and the frequency and number of questions which come from these topic is also higher. That's why I have choose this topic. Very good evening Sonam. So let's get into the session. Today we are going to completely discuss about anti-arrhythmic drugs and their classifications and the important high yield MCQs followed by it. Right? So be with me so that you will be having a clear picture from the beginning to the end in this particular session. So first and foremost thing is, what is mean by anti-arrhythmic drugs? So whenever there is a normal rhythm and normal heart rate, okay, there is no problem and heart is functioning so properly. When there is any abnormality in the electrical conduction system of the heart, we need this anti-arrhythmic medications to treat it, right? So to be very basic, and you know your heart is divided into 2 atriums and 2 ventricles. This is very basic, you know. And the most important thing which you have to note here is the conduction system of the heart. As you all know, the SA node, okay, the SA node is one of the most important node, which is the primary node which generates the action potential, right? And then we have the AV node, okay, we have the AV node, which is an important particular node which is responsible for carrying the impulses from the atria to the ventricles. Next we have your bundle branches, right bundle branch and left bundle branches, and your Purkinje fibers, right? This is how the impulses is going and reaching the ventricles from the SA node via the AV node and then to the bundle of Hess and then to your Purkinje fibers, right? So now why we are learning this component is, here you have to learn very clearly, like which are all the following rhythms are occurring in the atria, which are all the following abnormal rhythms are happening in the ventricles, right? So SA node, it is the normal pacemaker of your heart, okay? Your SA node is the normal pacemaker of your heart, okay? Normal pacemaker of your heart, and which generates the action potential Okay, or it purges electricity at the rate of 60 to 100 beats per minute. 60 to 100 beats per minute, as you all know. So this is the normal rhythm, right? When the heart rate is going greater than, okay, when the heart rate is going greater than 100 beats per minute, okay, we are telling it tachycardia. Okay, we are telling it tachycardia. And when it is going less than 60 beats per minute, we are terming it bradycardia. Okay, and you can put a word sinus tachycardia or sinus bradycardia, that is so clinically relevant term. It is sinus tachycardia or sinus bradycardia. When the heart rate is more than 100 beats per minute, you term it as sinus tachycardia, and when it is less than 60 beats per minute, you are terming it sinus bradycardia. And when it is between the normal range, you are telling it is a sinus rhythm. It is telling, you are telling it is a sinus rhythm. Okay, you are telling it is a sinus rhythm. This is the basic concept, right? So next, the most important component which you people have to remember is when SA node is generating abnormal, potential is developed in abnormal way because of any ectopic foci. For example, if you consider these are the ectopic foci. These are the ectopic foci. What is meant by ectopic foci? Like if other than the SA node, if some other, because of some other preceding condition, some other etiology, other particular mechanism are activated and the electrical impulses are generated in different manner, in an irrelevant way, we are terming it as ectopic foci. So ectopic foci, one of the major things which we have the condition is your SVT. That is your supraventricular tachycardia. Always remember supraventricular tachycardia, which means it is superior. It is superior. It is superior to the ventricles, which means it is at the level of atrium. So supraventricular tachycardia, we have three conditions, that is your paroxysmal supraventricular tachycardia, your PSVT, and your atrial fibrillation, and your atrial flutter. These are the condition which is coming under your supraventricular tachycardia, and it is limited to towards your atrium. When we are talking about your ventricles, here you have your VT and VF. That is your ventricular tachycardia and your ventricular fibrillation. Right? So this is very important part to know. So you have learned this. So the most important part you have to learn is the action potential mechanism. What is happening inside the cardiac muscle and what is happening inside the SA node. So you all know generally, to be with the basic understanding, you will be knowing that anti-arrhythmics are classified into sodium channel blockers, potassium channel blockers, calcium channel blockers. But what is the reason behind blocking those channels? That you have to know. And there is always a differentiation between the myocardial cell and the SA node, right? So when the limitation is with the SA node, you have to understand the limitation is with the atrium. When we are dealing with the myocardium, we are dealing with the ventricles, right? Because ventricles play a vital role in purging the blood outside. Okay, right? Hindi and English language use kar sakte. My dear Anush, I know very little Hindi. Okay, so I'll be very slow so that you will be understanding definitely. Okay. No need to worry about the language. It will be in English, but I will make sure you understand the concepts so that I'll be in a very slow pacing, right? So here, the most important note you have to note is this slide. Okay, so this particular action potential is for your myocardial cell. This is for your myocardial cell. In myocardial cell, okay, you all know the resting membrane potential. The resting membrane potential of the heart is minus 90 millivolt, right? Right? So this is the resting membrane potential of the heart. So of the myocardium, please make it sure, please make a clear note, it is the resting membrane potential of the myocardium, right? So first, what is happening? This is the myocardial cell. Okay, this is the myocardial cell in which the potassium, the sodium, which is getting inside and outside and making all these electrical impulses and generating all these electrical impulses. So first and foremost, you have to know what is the phases of the action potential. First, if you note, this is the final phase. No need to see this. First is your phase 0. Phase 0 is happening because of your sodium channel opening. Sodium channel opening. O stands for opening. Your sodium channel is opened, which means sodium which is outside the cell, which is getting inside and making the cell positive. Okay? Making the cell positive. Next, you have a peak and slight deflection here. That is called as phase 1, which is happening because of the potassium channel opening. So potassium channel opening means the potassium is coming from inside of the cell to outside. Right? Then you have a slanting straight line. This is called your calcium channel opening, and this phase is otherwise known as the plateau phase. The plateau phase. Okay, where the action potential is maintained. Then you have the third phase. This also happens because of your because of your potassium channel opening, right? Then again, this phase is called as your hyperpolarization. Hyperpolarization. And you have a different name. This sodium channel is opening. First and foremost stage is your sodium channel opening. Sodium channel opening, which is termed as depolarization. Depolarization means making the myocardial cell to be positively charged. Okay. Next we have what? Next we have your potassium channel opening. Potassium channel opening, which is called as early rectifier. Which is called as your early rectifier. Early rectifier. Next what we have? Next we have our calcium channel opening. Calcium channel opening, which we term it as your समझ नहीं आ रहा है. See, you want to talk to me in Hindi or what? I can talk in, like, I cannot talk in Hindi that much. Okay, so I will make sure that it is very slow so that you can able to understand. So next is calcium channel opening. As I said, calcium channel opening is called as your plateau phase. Okay, plateau phase. Then we have again the potassium channel opening. Potassium channel opening, which is termed as your repolarization. At last you have your phase 4, that is termed as your hyperpolarization. Hyperpolarization. So these phases are very important to note. First and foremost, you have to understand phase 1. Phase 1 is your sodium channel opening. Okay, phase 1 is your sodium channel opening. Okay, phase 1 is your sodium channel opening, which is the responsible for depolarization. Always remember what is the important point you have to notice. Which of the following ion is responsible for depolarization in the myocardial cell? If there is an MCQ, what you are going to take? You are going to take sodium. You are going to take sodium. Sodium is responsible for depolarization. What is meant by depolarization? Making the cell positively charged, making the myocardial cell positively charged, right? So which of the following ion is responsible for depolarization in the myocardial cell? It is your sodium, right? Don't confuse yourself. Be like what I am telling, just concentrate on that. That is more than enough, right? So sodium is one of the important ion which is responsible for depolarization in the myocardial cell. Okay, so that is your phase 1. What is phase 2? Phase 2 is your early rectifier phase, where your potassium is coming outside because of the potassium channel opening. Next we have phase 3. In phase 3 you have the calcium channel opening. So what happened? Lot of calcium efflux is there. Then at last what happened? We have the phase 4, that is the repolarization phase, which is again happening because of the potassium channel. potassium channel opening. So that is what you have to remember. First is in phase 1, it is because of the sodium channel opening, and it is called as depolarization. Second, phase 2 is called as potassium channel opening. It is called as early rectifier stage. And third stage, phase 3, is termed as for the calcium channel opening, and it is termed as your plateau phase. Next, we have the phase 4, that is your potassium channeling opening. That is the repolarization phase. So in myocardium, what is happening? This is happening like sodium channel is opening, then the potassium channel is opening, then the calcium channel is opening, then the potassium channel is opening, and again after hyperpolarization again the sodium channel, like that it is happening. The depolarization is happening synchronously. When we talk about the SA node, SA node's action potential starts at minus 60 millivolt. SA node's action potential starts at minus 60 millivolt. And what is the important thing you have to notice? So here there is always a gap between one repolarization and then to the depolarization, right? So in this case of SA node, why we are giving time for depolarization in case of your myocardial cell is, once the ventricle is getting the blood, it needs some time to push it out. So that's why what is happening, the depolarization and repolarization is happening with a good pace. But here in SA node is in the responsibility that it has to generate the impulses so regularly and so spontaneously, right? So that's why it happens very fast. So here the most important point which you have to only note is, here who is initiating the depolarization? In SA node, which ion is initiating the depolarization? If you are going to click sodium, it is wrong. In SA node, which ion is going to take the responsibility for depolarization? In SA node, the depolarization is activated by your calcium. Here calcium channel open, okay, calcium channel open, and then the potassium channel open. So this is what is happening in this particular phase. So what you have to remember is only simple things. Depolarization is initiated by sodium channel in case of myocardial cells, and depolarization is initiated by your calcium channel in case of your SA node, right? This is the only thing you have to remember, okay? So if we are talking about how we are going to administer the medications, if there is some problem in the SA node, what will be the drugs you will be giving more priority? Obviously, you have to give sodium channel blockers, right? If the an impaired electrical event is happening below the atrium in the ventricles, then what will be the drug of choice? It will be obviously see here, whenever the problem is with the SA node, as I said you, the depolarization is happening because of the calcium channel. Please remember this only, right? It is happening because of the calcium channel. You're going to give calcium channel blockers. When the bifurcations or ectopy is going to happen in the ventricles, what is the depolarization agent? Kindly answer me. What is the depolarization agent? What is the depolarization electrolyte which is present in the myocardial cell? Depolarization electrolyte in myocardial cell. Now tell me, put me in the chat box, like what is the depolarization electrolyte in the myocardial cell? And you also have to tell me depolarization electrolyte in SA node. This is very important. Now tell me what is the answer. Very good, very good, very good, very good. So depolarization electrolyte in the myocardium is sodium. Very, very important point to note. And the depolarization electrolyte in SA node is, now tell me what is for SA node. Very good, Priya, Muva, Bubu, Matavallam, SR, Mukesh, Dharmaraj, Sonam, everyone. So what is the depolarization electrolyte in SA node? Yes, boo-boo, it is very good. It is calcium. This is the only thing you have to remember, okay? And you have to remember the phases also. But as of now, you remember this is more than enough, right? For SA node, it is calcium. For your myocardial cell, it is sodium. So the drug of choice will be depending upon this. If the ectopa is going to be in the atrium, because atrium is completely responsible with the SA node, so I will give calcium channel blockers. If it is in the ventricles, it is targeting the myocardial cell. So my target of drug of choice will be what? My targeted drug of choice will be what? Sodium channel blockers. So this is how you need a clarity. So next we will go for the classification. So how to remember the classification in EC way is, this is your myocardial cell, okay, this is your myocardial cell, sodium is outside, okay, and your beta receptor is in the outside, and inside the cell you have potassium, and inside the endoplasmic reticulum you have the calcium, right? You are going to remember this, you are going to remember the classifications of your anti-arrhythmic drugs with the help of this diagram. So first we will complete the outside and we will go to the inside. So your sodium channel blocker is the class 1, okay, class 1 anti-arrhythmic drugs or your sodium channel blockers. Class 2 is your beta blockers, so outside of the cell is completed in your myocardial cell. Next, class 3 is your potassium channel blockers, and class 4 is your calcium channel blockers. Is that clear? Consider this is a myocardial cell, and outside, you know, outside sodium is there, and outside the cell you will be having the beta receptors, and inside the cell you have the potassium, and inside the sarcoplasmic reticulum you have the calcium, right? So in such a way we are going to classify this anti-arrhythmic drugs. So outside, first we are going to complete. So outside, sodium channel blocker, class 1 anti-arrhythmic drugs, class 1 anti-arrhythmic drugs or sodium channel blockers, class 2 anti-arrhythmic drugs or beta blockers, class 3 anti-arrhythmic drugs or potassium channel blockers, and class 4 anti-arrhythmic drugs or your calcium channel blockers. So now we are going to the actual movie now. Like here we have your classifications. As I said your first class is your first class of anti-arrhythmic drugs. Class 1 is your sodium channel blocker. Right? It's your sodium channel blocker. So sodium channel blockers further has 3 classifications. That is 1A, 1B and 1C. It is 1A, 1B and 1C. So 1A drug is your quinidine, prosinamide, and you also have another drug that is your disopyramide. Right? The most important exam question which you will get from this particular class 1A drugs is class 1A drugs. So tell me, what is the important component you have to note in class 1A drug? What is the important side effect of class 1A drug? Now tell me, what is the important side effect of class 1A drug? Yes, any active student, any pure NORCET aspirant can answer this question. Class 1A drugs has the side effects of what, or it causes what findings in the ECG? Anyone? And this person is going to definitely get a compliment from me. Yes, Muva, Matavalam, Sonam, tell me. No people have idea? Yes. See, remember, hypotension, no, I'm asking specifically with ECG findings. Please remember, important exam question. Your class 1A drugs causes QT prolongation. QT prolongation. Okay. your class 1A, which means in sodium channel blockers, your class 1A specifically causes QT prolongation. All three drugs causes QT prolongation. All three drugs causes QT prolongation. Is that as clear? All three drug causes QT prolongation. Yes, dysarrhythmia is a common term, but you have to remember in exam point of view what they are going to ask is which of the following drugs is going to cause QT prolongation if there is a question. So you have to see for this quinidine, prosinamide and disopyramide. Like these are the anti-arrhythmic drugs in sodium channel blocker which is going to specifically cause QT prolongation. But we also have other drugs also which is going to cause QT prolongation, which I will be discussing with you in future in upcoming slides. Right. So first and foremost thing is when you learn about class 1A drug, what is the MCQ point is you have to remember this class 1A drug, that is your quinidine, prosinamide and disopyramide causes QT prolongation. That is one of the important side effect of this drug. Important side effect of this drug. Right. So quinidine, as you all know, quinidine is given in the oral form, and the most important side effect, as Priya said, like it causes hypotension. Okay, it causes hypotension and it causes tinnitus and vertigo. Tinnitus and vertigo. Next we have prosinamide. Prosinamide is also an important drug. This prosinamide causes SLE. So what is the important nursing interventions you have to remember is prosinamide causes SLE, so that you have to instruct the patient regarding the SLE symptoms so that the patient will report to you immediately and you will do further management. So prosinamide has the side effect of, this is also a side effect of causing SLE, and it also causes agranulocytosis. Agranulocytosis. Next we have disopyramide. Disopyramide causes constipation and dry mouth. So this is the important things you have to remember. Which of the following drugs causes QT prolongation? You have to classically think it is class 1A drugs, right? And quinidine has an important side effects that includes your hypotension, tinnitus and vertigo. In prosinamide, prosinamide causes SLE, so that SLE related symptoms has to be instructed to the patient, and patient will go for agranulocytosis also. This agranulocytosis is going to elevate the infections. It is going to elevate the infections. Next we have the disopyramide. Disopyramide is an important drug which causes side effects of constipation and dry mouth. So next we have this sodium channel blocker class 1B. Everyone learnt about lidocaine, but you people don't know lidocaine comes under which classification. Lidocaine comes under sodium channel blocker and it is a class 1B drug, right? Lidocaine is a sodium channel blocker and it is a class 1B drug. So now tell me, what is the important action of lidocaine, or where this is a drug of choice? Where this is a drug of choice? Lidocaine is an important drug of choice if the patient is going to have MI, ischemia, okay, MI, ischemia, any ischemia or myocardial infarction related induced VT or VF, okay, ischemia, induced VT or VF. And again, digoxin induced VT or VF. Digoxin induced VT or VF. This lidocaine is going to be an okay, this lidocaine is going to be a important drug. Next we have mexiletine in class 2B. Okay, next we have mexiletine in class 2B. Next in class 2C you have flecainide and propanol. These both flecainide and propanol is the most arrhythmogenic drug. arrhythmogenic drug. Most arrhythmogenic drug. In that, flecainide is the most arrhythmogenic drug. Now tell me, flecainide is a drug of choice for which condition? Flecainide is a drug of choice of which condition? I'm waiting for your answers. Flecainide is a drug of choice of which particular condition? Local anesthesia? No. I'm talking regarding the cardiac related, like cardiac related conditions. Now tell me, flecainide, you have to remember, whenever they are asking about Wolff-Parkinson-White syndrome's drug of choice. Okay, flecainide is an important drug of choice of Wolff-Parkinson-White syndrome. Drug of choice in Wolff-Parkinson-White syndrome. Okay, that is termed as your WPF syndrome. And here we have thought about the drug of choice of lidocaine. Lidocaine is the drug of choice when the patient is a case of myocardial infarction, ischemia induced or digoxin induced. If the patient is getting VT or VF, in that case your drug of choice is going to be lidocaine. But the primary drug of choice is different. But if the patient is having this particular accompanied disease conditions, then you're going to give what? Lidocaine. Yes, very good, boo-boo. Yes. Next we have class 2 drugs, that is beta blockers. In beta blockers, you know, we have propanol, metoprolol and esmolol. Propanol and metoprolol are oral drugs, whereas esmolol is an IV drug. And whenever you have, you can able to correlate, like whenever drug is given in IV, it is given in emergency situation, right? And what is the action it is going to do? Beta blockers is AV nodal blocker. AV nodal blocker, and it is given in many conditions to control the heart rate. That is otherwise commonly termed as rate controller. Okay, that is otherwise commonly known as rate controller, right? So next we have potassium channel blockers. The most important drug which you have to note in potassium channel blockers is your amiodarone. Amiodarone is your potassium channel blocker, and sotalol and dofetilide, and we also have another drugs which we will see. So this particular drug, potassium channel blockers, causes an increase in the QT interval. So as we discussed in the first slide, so this particular depolarization and repolarization interval will be coinciding with your QT interval. So now if I am going to give the potassium channel blocker, what will happen? This potassium channel blocker is going to increase the depolarization. That's why this potassium channel blocker is causing the prolongation of the QT interval, right? And the most important thing you have to note is, as I said you, in the MCQ point of view, your class 1A drugs causes QT prolongation, and your class 3 drugs also causes QT prolongation. Very, very important MCQ point you have to remember. Like, which of the following anti-arrhythmic medications, select all the anti-arrhythmic medications which can cause QT prolongation. So you have to select only the drugs from class 1A, from sodium channel blockers, that too in 1A, that is your quinidine, prosinamide and your disopramide, right? So next, here in class 3, potassium channel blockers, which is going to cause the QT prolongation, right? So drug of choice related things we will be seeing in upcoming. Okay, the last classification is your calcium channel blockers. So calcium channel blockers, as you all know, verapamil and diltiazem. When the patient is having the case of COPD or asthma, in this case you are going to use this as a drug of choice in the arrhythmias, right? And this particular medication is going to increase the PR interval. And the most important complications, it's a side effects of this is constipation. Okay, constipation, hypotension, and bradycardia. Always remember beta blockers, since the action itself to cause bradycardia, they are also having the higher risk of getting bradycardia, right? So next, here we come to the real picture of this particular class, like what is the drug of choice for what condition, right? So first we are going to talk about your SVT, PSVT, atrial fibrillation and atrial flutter, right? So first, whenever you get an SVT in an acute attack, when the patient is initially diagnosed with an SVT or PSVT or atrial fibrillation or atrial flutter, your first and foremost drug of choice is going to be your adenosine, beta blockers, calcium channel blockers and digoxin. Beta blockers, calcium channel blockers and the what? And your digoxin. So what you know about adenosine? Okay, so one of the most important point which you have to additionally notice, we also have miscellaneous drugs. Okay, we also have miscellaneous drugs in your anti-arrhythmics. Okay, miscellaneous drugs in your anti-arrhythmics. That is your atropine, MgSO4, your adenosine. What is the other drug? Tell me. I have mentioned the 4 drugs. What is the other drug? And your digoxin. So these are the miscellaneous drugs which is present in the anti-arrhythmic classification that you have to remember, set aside. These are the 4 drugs: atropine, magnesium sulfate and your adenosine and your digoxin, or the miscellaneous anti-arrhythmic drugs. So here you have to remember, whenever the patient is getting an acute attack of SVT or PSVT, your drug of choice is going to be adenosine, beta blockers, calcium channels and digoxin blockers. In acute attack, you need immediate management. In beta blockers, you're going to administer esmolol in IV because it is going to have a rapid effect. In calcium channel blockers, you're going to administer verapamil in IV. So whenever you're going for oral, in case of chronic condition for controlling the rate and rhythm, you're going for oral administration. So here you have an important classification. When the patient is a case of PSVT or SVT, if the BP is low and the patient is unstable, whenever the patient is unstable or he is becoming unconscious, in that case you're going to give cardioversion to that particular patient, because whenever the rhythm is originating at the atria level, it is regularly irregular, right? What happened there? You can able to give cardioversion. Cardioversion delivers your synchronized shock, which means it delivers at your QRS complex, specifically at the R wave, it will be delivering the shock. Right? So that's why if the patient is unstable, you are going to give cardioversion. If the patient is going to be stable and the BP is also normal, then initially first you will going to give the carotid massage. As you all know, carotid massage will stimulate your baroreceptor, and by means it stimulates the parasympathetic nervous system, and thereby it reduces the heart rate, right? So here, then if you are going to give carotid massage, if there is no proper evaluation after that, then what will happen? Then you are going to check for the history of asthma and COPD, because this particular adenosine is contraindicated in case of the patient is having asthma or COPD, because this particular drug causes bronchoconstriction, and if the patient is going to have like COPD or asthma, this administration of adenosine is going to even worsen the condition, right? So what you are going to do, if the patient is an unstable patient, you are going to give cardioversion to that particular patient. If the patient is a stable patient, what you're going to do? First you're going to do carotid massage. So if you like, there is very many ways to do vagal maneuver, right? So like here we have put carotid massage. So carotid massage, you will be doing the carotid massage, thereby you are stimulating the baroreceptor, thereby you are stimulating the parasympathetic nervous system, and the heart rate is reduced. Whereas in sympathetic nervous system stimulation, the heart rate is going to increase, right? So what is happening after carotid massage? If there is no proper response, then you are going to want the drug administration. Before administration of the drug, it is very, very important to note whether the patient is having the history of asthma or COPD. If at all the patient is going to have the history of asthma and COPD, you will not administer. Okay, if the patient is having the history of asthma and COPD, you will not administer adenosine. Okay, you will not administer adenosine. If the patient is presented with asthma and COPD, then you are going to give your calcium channel blockers. So if the patient is going to have asthma and COPD, what you are going to do? You are going to give diltiazem and verapamil. If the patient is not having the history of asthma and COPD, you are going to give adenosine in an IV rapid push. As you all know, I was working in a cardiac ICU. So what happened, initially my patient has got SVT. So what happened, we were getting really very hurry to get ready with the medications of adenosine. So what happened, my TL was loading an adenosine, along with that he was loading a 10 ml normal saline flush. So what we were doing is, like, he has established a large bore catheter in large bore IV in the left side of the hand, and he has administered the adenosine, and he has given, followed by immediately he has given a rapid push of normal saline. So what happened, immediately you can see an asystole in the patient's ECG monitor, cardiac monitor, and followed by what will happen, the patient will be reverting to the normal rhythm. Right. So this is how adenosine is administered, and the dosage is 6 mg, and if the patient is not responding, then we can go for 12 mg also. The shortest acting drug in the anti-arrhythmic drug is your adenosine. Adenosine is the shortest acting drug. Okay, shortest acting drug. That too, it has the shelf life of 10 seconds. It has the shelf life of 10 seconds. That's why we are administering this medication in the rapid push. In the rapid push. You are administering this medication in the rapid push. Right? If the patient is going to have asthma or COPD history, you are not going to administer adenosine because it can cause bronchoconstriction. So you are going to treat the patient with diltiazem and verapamil. Right? This is all about your SVT. Always remember, in acute attack, you are going to give all these medications such as adenosine, beta blockers, calcium channel blockers, and the digoxin. And for maintenance, for long term, in this case, you are going to give calcium channel blockers, beta blockers, and digoxin in the oral form. Right? If the patient is getting the VT, what is the drug of choice? If basically, if they are giving the question, and if they are giving, like, what is the drug of choice? Okay. Yes, AIMS MSc result has came. We will celebrate soon. Like, many of my students has got selected, I know. And very, very congratulations to all my MSc nursing students who got selected. Coming back to class, after class I will address about this. Okay. So what I was talking, like, when they ask a simple question without any particular previous history of asthma or COPD, you have to definitely think about adenosine. SVT, PSVT, AF, atrial fibrillations and all, you have to definitely think about what? Your adenosine. Adenosine is the king drug for treating this thing, and it is the drug of choice. If at all the patient is having the history of COPD and asthma, then you're going to search for the options for the diltiazem and verapamil, right? And always remember, the another important point is adenosine should be always administered in rapid push because its shelf life is 10 seconds only, right? And when they are asking what is the most, like, which of the following drug is the most shortest acting drug in anti-arrhythmics, your answer should be adenosine. So these are all the important points you have to remember. So adenosine and your beta blockers. Remember, adenosine as well as your beta blockers will cause bronchoconstriction. What are the side effects of adenosine? First and foremost is adenosine causes atrial fibrillation. Okay, atrial fibrillation, and it causes hypotension and flushing also, right? So when digoxin is indicated, as I said you, digoxin is also one of the miscellaneous anti-arrhythmic drug. Okay, So here digoxin is indicated if the patient is a case of SVT and PSVT and he is having chronic congestive heart failure plus chronic congestive heart failure. Okay, so then you're going to treat the patient with the digoxin. So when they are going to give the scenario like the patient is a case of SVT or PSVT and she is having the congestive cardiac failure, then what will be the drug of choice? Then you have to think about digoxin only, right? The primary drug of choice is adenosine, but if the patient is going to have COPD or asthma, you're going to give verapamil or diltiazem to the patient. If the patient is having chronic congestive cardiac failure, then you're going to think about digoxin. So when we discuss the MCQs now, it will be very clear for you. Next, we are going to talk about atrial fibrillation. In atrial fibrillation, in case of acute attack, you're going to give cardioversion plus ibutilide. In acute attack, you're going to give cardioversion plus ibutilide for controlling the rate. Okay. Always remember, in case of acute or chronic condition, to control the rate, your ultimate drug of choice will be beta blockers. Okay, beta blockers. So, as I said you, adenosine and beta blockers causes bronchoconstriction. So, here also there is an exception. If the patient is going to have the history of COPD or asthma, then again I am going to shift the patient to calcium channel blocker for rate controlling. Right? Okay. If the patient is not having the history, I am going to directly administer beta blockers as a drug of choice for the rate controlling in atrial fibrillation. If the patient is not a case of, if a patient is a case of COPD asthma, as I said you, beta blockers and your adenosine is a contraindication for the patients with COPD and bronchial asthma, right? So next, for the rhythm control, the ultimate drug of choice is amiodarone. Amiodarone, the king drug. Okay, amiodarone is the drug of choice in case of chronic attack of your atrial fibrillation. And the most important thing is amiodarone has many actions. Amiodarone is a potassium channel blocker, it's a calcium channel blocker, it's a sodium channel blocker, and it also a beta blocker. So it has multiple anti-arrhythmic effects. Okay, the primary mechanism we are considering is potassium channel blocking, right? But it also has these following actions. And amiodarone is one of the drug which has the longest acting power. Okay, the longest acting drug. When there is an MCQ, which of the following anti-arrhythmic drug is longest acting? Then your answer is going to be amiodarone. So for how many days? It acts for 53 days. 53 days. And you all know the dosage, 300 mg we are going to give, right? And we also have to learn about the side effects of amiodarone, which we will be learning in the future, right? Or else we will learn now. It is very important to learn about the side effects of amiodarone. So to learn the side effects of amiodarone, you are going to remember a short mnemonic. Not a short mnemonic, quite big mnemonic. Okay. Potassium channel blockers make the liver and skin toxic. Okay. You have to remember potassium channel blockers make the liver and skin toxic. Okay, potassium channel blocker make the liver and skin toxic. Potassium channel blocker make the liver and skin toxic. That is the mnemonic you have to remember for this particular amiodarone. So P stands for your pulmonary fibrosis. Pulmonary fibrosis. That's why you have to take a chest X-ray before giving this particular drug. Okay, that's why you have to take the That's why you have to do what? You have to do a chest X-ray before administering this particular drug. Okay? Then C stands for your corneal microdeposits. Corneal microdeposits. And again, B stands for blue skin. Okay, blue skin. Okay, blue skin. B stands for your blue skin. And again, your S stands for your brown skin. Brown skin. That's why we are going to administer and inform the patient that they have to wear the sunscreen during this thing. And M stands for myocarditis. Myocarditis. And L stands for liver toxicity. Okay. M stands for myocarditis and L stands for liver toxicity, and your A stands for alpha receptor blocking. So alpha receptor blocking, so that's why the patient is going to get hypotension. And I stands for your hypothyroidism. Okay, T stands for your thyroid dysfunction. That is, hypothyroidism is more when comparing to hyper. Right? So you have to remember potassium channel blockers. Okay, I'll write here. You have to remember potassium channel blockers make liver and skin toxic, right? So potassium, P stands for your pulmonary fibrosis. That's why we have to take a baseline chest X-ray to those particular patients. Next, channel, C stands for corneal microdeposits. These patients will be having corneal deposits. And B stands for blue skin. And again, you have to come to the S, that is talking about the skin, that is brown skin. That's why you have to instruct the patient to avoid excessive sun exposure, and you have to instruct the patient to do sunscreen, right? And M stands for myocarditis, and L, liver toxicity, and A stands for your alpha receptor blockage, which in turn going to cause hypotension, and T at last stands for thyroid dysfunction, that is hyperthyroidism is more common than hyperthyroidism. Okay, this class is completely in English. Okay, so next we have ventricular fibrillation and tachycardia. So in ventricular fibrillation and tachycardia, okay, what are the drug of choice? So for ventricular tachycardia, the ultimate drug of choice is your amiodarone. Just remember, for ventricular tachycardia, your drug of choice is amiodarone. Next, if the patient is going to have digoxin or ischemia induced VT or VF, then you are going to give lidocaine, a sodium channel blocker, right? So this is the potassium channel blocker. This is the potassium channel blocker, and this is the sodium channel blocker, right? And if the patient is a VF, the treatment of choice is ultimately defibrillation. Drug management don't work for it. The treatment of choice is defibrillation. Remember, in case of ventricular fibrillation, the treatment of choice is defibrillation. If the patient is a case of VT, then what is the drug of choice? If there is an MCQ, then you're going to click it as a amiodarone. Right? So next, long QT syndromes, which is, see, whenever the patient is going for QT prolongation, this particular QT prolongation will lead to torsade D points. This particular QT prolongation will lead to torsade D points. So what happened, like what is the drug management is, if the patient is an acute attack of torsade D points, you're going to give magnesium sulfate IV. as a drug of choice. What is the drug of choice for torsade D points? Please keep in mind it is magnesium sulfate, right? So the most important point you have to note while administration of magnesium sulfate is, as we discussed about adenosine, it has to be given in rapid push. This magnesium sulfate has to be given in slow push. This magnesium sulfate has to be given in slow push. If at all you are going to give it in a rapid push, it is going to cause various side effects, which includes your apnea, hyperreflexia, and all, right? Hyperreflexia. So it is very important to note, magnesium sulfate, always you have to remember it has to be administered in the slow push, right? So next, in case of long term, the patient is having this QT syndrome. If it is congenital, you are going to treat it with beta blockers. If it is acquired, what is meant by acquired? I don't have any history of QT prolongation, but because of some triggering factors, which means many drugs causes QT prolongation, right? So you all remember the first 2-3 slides, your class 1A drug and class 3 drugs. Why I am keep on reinforcing this is very important question point of view. Which of the following drugs causes QT prolongation in the anti-arrhythmic classification? In anti-arrhythmic classifications, your class 1A drug and class 3 drug is going to cause QT prolongation. So in class 1A, as you all know, quinidine, prosinamide and disopyramide. And in class 3, you have sotalol, amiodarone, dornidarone. What is dornidarone? Dornidarone is having the same combination of amiodarone, but it does not have iodine. It does not have iodine. And dofetilide, ibutylide and your venaclant, everything is coming under your what? Class 3 anti-arrhythmic drugs. What is your class 3 anti-arrhythmic drugs? Please answer me. What is the class 3 anti-arrhythmic drugs? What is the class 3 anti-arrhythmic drugs? It is your potassium channel blocker, right? So next, what are the other drugs which causes QT prolongation? You know, quinidine, that is a class 1A drug, quetiapine, methadone, moxifloxacin. Moxifloxacin is the most common drug or most potent drug to cause QT prolongation. Macrolides, bedaquiline and delmanid, and your acetamizole and your tefnarin. So Wolff-Parkinson-White syndrome, in case of acute, you are going to give prosinamide. Please remember, acute, you are going to give prosinamide. If it is chronic, you are going to give, in long term, the drug of choice is your flecainide. And flecainide, I said you, it is a most arrhythmogenic drug, right? So digoxin, what are the side effects of digoxin if the patient is going for digoxin toxicity? What are all the things you can see? Like you have to remember with the short mnemonic, that is digoxin. Okay, where D stands for your dialysis and disequilibrium, I stands for increased potassium. Always remember, whenever the patient is having increased potassium, he is not at the risk of digoxin toxicity. This is after side effects, which means this is the side effects or digoxin toxicity effects. Okay, patient before administration, if he is in hypokalemia, okay, very important concept to remember. So before going for digoxin administration, you are monitoring the patient's potassium level, and the patient is in hypokalemia. In that case, the patient is having highest risk to get digoxin toxicity, because your hypokalemia, which is decrease in potassium, what it is causing, why it is causing digoxin toxicity means, both digoxin is a cardioglycoside which is having the action of sodium potassium ATPase pump inhibitor, right? In the body, your digoxin and your potassium will try to bind to the receptors will try to bind to the receptors. If at all there is less level of potassium, what will happen? More digoxin will bind. If both of them is if potassium is in the normal level, potassium will also bind, digoxin will also bind, and there will be normal effect mechanism which we actually want to treat the patient. If at all the potassium is going to be reduced, then what happened? The digoxin will bind maximal to the receptors, which is going to cause toxicity. I hope you understand this. If you have any doubts, you can ask in the chat box, right? When the patient is on hypokalemia, the patient is having increased risk of digoxin toxicity, you have to remember. On the other hand, when the patient is getting digoxin toxicity, then he will get hyperkalemia. Right? Then he will get hyperkalemia. Next we have G stands for gynecomastia, O stands for ocular side effects, which means the patient will be having green halos, and X stands for xanthopsia, that is yellow halos, and I stands for increased risk of arrhythmia. Whenever they are going to ask a question like which of the following arrhythmia is very common when the patient is on digoxin toxicity, the most common arrhythmia which is accompanied with digoxin toxicity is your ventricular bigeminy. Your ventricular bigeminy is the most common arrhythmia which can be caused because of the digoxin toxicity. At last, N stands for your nausea and vomiting. And now it is very important for you people to again note which of the following increases the risk of digoxin toxicity. Okay. Which of the following components increase the risk of digoxin toxicity? Factors causing increased risk of digoxin toxicity. Remember, with the short mnemonic, KMC reduces major health worse. Just you have to remember, KMC reduces major health worse. What is that? KMC reduces major health worse. So now we will learn what is the expansion. For K stands for, hypokalemia. M stands for hypomagnesemia. And very, very important to note, C stands for hypercalcemia. It is not hypo, remember it is hypercalcemia. Okay, C stands for hypercalcemia. So R stands for renal failure. Okay, R stands for renal failure, and M stands for your myocardial infarction. Your H stands for hypertrophic obstructive cardiomyopathy. HOCM. H stands for your hypertrophic obstructive cardiomyopathy, and W stands for your Wolff-Parkinson-White syndrome. See, here you have to remember these are the side effects of digoxin toxicity. When the patient is going for digoxin toxicity, that is the side effects that you have to remember with the mnemonic digoxin. Here we have seen like which of the following factors cause the increased risk of digoxin toxicity. Then you have to remember the mnemonic KMC reduces major health worse. So where K stands for hypokalemia, M stands for hypomagnesemia, C stands for hypercalcemia, R stands for renal failure, M stands for myocardial infarction, H stands for hypertrophic obstructive cardiomyopathy, and W stands for Wolff-Parkinson's White syndrome. So now we have came to the important part, and I want now everyone to be very active in answering the MCQs. Yes. The first MCQ, a 28 years old woman present with sudden onset of palpitations, and ECG reveals narrow complex regular tachycardia at 180 beats per minute, narrow complex regular tachycardia at 180 beats per minute, and she is hemodynamically stable, and she has no history of asthma or COPD. What is the most appropriate first line pharmacological management? Now, I request everyone to start giving your answers. I request everyone to start giving your answers. Yes. What is the correct answer? Very good, very good, very good. So obviously here if you see the narrow complex regular tachycardia, the narrow complex regular tachycardia is your, what is the diagnosis here? It is PSVT. It is PSVT, and the patient is also stable. And she does not have any history of COPD or asthma. So your ultimate drug of choice is adenosine. So a very good applause for my dear children like Nirmala Mary, Dibash, Dharmaraj, Bubu, Matavalam, Priya, Gunjan, Muva and Maina. Right? So next question. A 22 years old female present with polymorphic VT, polymorphic ventricular tachycardia, suggestive of Torsades points, directly they have given. Okay, her ECG reveals a prolonged QT interval. Her ECG relieves a prolonged QT interval. What is the immediate drug of choice? Now tell me, the patient is a case of Torsades points. So directly they are putting a lot of additional words to confuse you people and to waste your time. But the ultimate thing they are trying to explain here is the patient is a case of Torsades points and the ECG is revealing prolonged QT interval. Yes, prolonged QT interval is one of the ultimate cause the patient will be going for Torsades points, right? So now tell me, what is the drug of choice when the patient is a case of Torsades points? Very good. Many people started giving the correct answer. Devesh, Gunjan, Bubu, Nirmala Mary, Matavalam, Muva, Priya and Dharmaraj. And my dear people, you are the best. You are the best. Obviously, it is magnesium sulfate. Now we will have a basic questions, and few like upcoming questions will be quite tricky. Let me see, you people are very active in answering those questions or also. Right? So now tell me, in which of the following scenarios digoxin most appropriately indicated? In which of the following scenarios is digoxin is most appropriately indicated? The first option is acute PSVT in young male with normal ejection fraction, chronic SVT in patient with coexisting chronic congestive heart failure, atrial fibrillation with Wolff-Parkinson's-White syndrome, ventricular tachycardia post-MI. Now, I request you people to give the answer. What is the correct answer? Yes, many people have started giving the correct answer. As I said you, when the patient, okay, like I said you, digoxin is one of the important cardioglycoside drug, which is coming under the classification of miscellaneous antiarrhythmic drug. But its action is your sodium, potassium, ATPase pump inhibitor. ATPase pump inhibitor. As I said you, whenever we talking about this particular digoxin, as I said you, when the patient is having an SVT, supraventricular tachycardia, and in the chronic management, we are going to use digoxin. That too, the most classical point you have to remember is when the patient is a case of congestive cardiac failure. When the patient is a case of congestive cardiac failure, definitely you are going to close your eyes and you are going to take the option B only. When the patient is having chronic SVT and you have to manage the patient and he is also having congestive heart failure, in that case your drug of choice will be digoxin. So that is the correct statement. In other statements are irrelevant to your digoxin. Now tell me, which of the following anti-arrhythmic drug primarily prolongs the repolarization phase, that is your phase 3, by blocking delayed rectifier potassium channel? So without affecting the resting membrane potential. Now you have to tell me the answer correctly, and this is a quite tricky question where you have to know the basic physiology before answering this question, right? So now tell me, which of the following anti-arrhythmic drug primarily prolongs the repolarization, that is phase 3, by blocking the delayed rectifier potassium channel? So to have a quick recap, okay, so we have phase, this color is very bright. Okay, we have phase 1. Now tell me, what is phase 1? Phase 1 is sodium channel opening, which is called as depolarization. Okay. Next, in phase 2, you have what? Potassium channel opening, and this is called early rectifier. Next we have the phase 3, that is your calcium channel opening, that is termed as your plateau phase. Then phase, sorry, it's a big blunder here. See, it starts from phase 0, okay? Don't confuse, sorry. See, it starts from phase 0, phase 1, phase 2 and phase 3, okay? Phase 0 is your sodium channel opening, depolarization. Phase 1 is your potassium channel opening, early rectifier. Phase 2 is your calcium channel opening, plateau phase. Always remember, now I have made a mistake. This mistake will be making you to remember even more strongly that always phase 0 is the one which is starting, which is the sodium channel opening, and that is termed as depolarization. Next we are going to talk about the phase 3. Phase 3 is again your potassium channel opening, that is termed as repolarization, and this stage is also called as late rectifier, and phase 4 is hyperpolarization. Yes. Now tell me, primarily prolongs the repolarization phase. If prolongation of the repolarization phase can be only done by means of, prolongation of the repolarization phase can be done only by your potassium channel opener. Now in the option you have to check which is the potassium channel opener. So flecainide is your, lidocaine is sodium channel opener. Flecainide is also sodium channel opener. Lidocaine is 1B and flecainide is 1C, and amiodarone is the potassium channel opener. Yes, verapamil is a calcium channel blocker, right? Potassium channel blocker. So that's why amiodarone is the correct answer, right? So many people has answered it correct, is very good. So remember, phase 3 is delayed or blocking action can be done by your amiodarone, that is your potassium channel blocker. So next, which anti-arrhythmic class is most likely to cause widening of the QRS complex without significantly affecting the QT interval. Okay? Which anti-arrhythmic class is most likely to cause widening of the QRS complex without significantly affecting the QT interval? Yes, I am waiting for the answers now. Please think critically and answer this question. Class 3 and 1. Yes. See, my dear children, I know you people will confuse when I put such question. That's why I put such question. Here, what the question is actually asking. Like, you have to remember, you have to read the question properly before giving a competitive examination. Attentiveness towards the question is very important. See here, which anti-arrhythmic class is most likely to cause widening of the QRS complex? They are asking which particular drug is going to cause widening of the QRS complex without significantly affecting the QT interval. If at all they are going to ask about QT interval, then your answer will be class 1A and class 3 drug. Okay, then it is a correct answer. Here they are only asking about the widening of the QRS complex. As we discussed earlier when I was discussing about class 1C, I said you flecainide is the most arrhythmogenic drug which causes widening of the QRS complex. Which causes widening of the QRS complex. The answer is class 1C drug. Class 1C's drugs are considered as the most arrhythmogenic drug. Most arrhythmogenic drug. And that is the drug which is leading to what? Which is leading to widening of the QRS complex without having any interaction towards your what? QT interval. Right? Is that is clear? See, class 1C, flecainide and propafenone. Okay, flecainide and propafenone. Okay, propafenone are the drugs of examples for your class 1C drugs, and they are considered to be the most arrhythmogenic drugs. Here where you have to understand like small nook and corner issues, nook and corner words in the MCQ is very important. You have to read the question so thoroughly before giving the answer. If at all, like I was keep on enforcing you like about QT prolongation, and simply after seeing the QT interval in the statement, you have decided that class 3 will be the action because class 1A is not in the option. It is not like that, right? You have to remember class 1C drug is considered as the most arrhythmogenic drug, which is going to cause your widened QRS complex without having any interaction with the QT interval. If they are asking about QT interval interaction, then your answer will be class 3, right? But a very good try, but very important to note is the MCQ's stem. Then the options. Now tell me, which of the following electrolyte abnormality increase the risk of digoxin induced arrhythmia? Be very clear. Read the question properly. Don't do the same mistakes you have done in previous question. Yes, now actively answer me. Which of the following electrolyte abnormalities increase the risk of digoxin induced arrhythmia? Yes, Dharmaraj. Yes. Very good. Now you have learnt how to analyze the question, how to read the question stem properly. Right. So, which of the following electrolyte abnormality increase the risk of digoxin toxicity? You have to remember they are asking which of the following electrolyte abnormality is going to increase the risk of digoxin toxicity. As I said you, there is a binding issue with digoxin and potassium. The answer is hypokalemia. Very good, everyone. Gunjan and Bubu, Priya, Nirmala Mary, Dibesh, Matavalam, Dharmaraj, Maina. Very good. So hypokalemia is the condition which causes the risk of the increase in the risk of digoxin toxicity. Remember, hypokalemia is going to cause increased risk of digoxin toxicity, whereas hyperkalemia is the side effect of digoxin toxicity. Again, what is the effect of hypermagnesemia? No effect. Hyponatremia, no effect. Right? Now, next question. You are a nurse in an emergency department. A 27 years old female arrives with sudden palpitation, lightheadedness, and heart rate is 185 beats per minute. ECG confirms narrow complex regular tachycardia, that is SVT. So blood pressure is stable and she has no history of asthma. You prepare to administer IV adenosine as ordered. What is the most critical nursing action during this adenosine administration? Yes, I am waiting for the answers. Yes, very good. As I said you here, these lines are literally waste your time, which means you have to read it attentively but also importantly, and you should not waste a lot of time to attend these questions. You have to concentrate on the last statements where they are telling the important keywords. I am administering IV adenosine as ordered. What is the most important critical nursing action during adenosine administration? So obviously you have to remember, inject the drug slowly over 1 to 2 minutes to avoid hypotension. No, the shelf life of the drug is 10 seconds. If you are going to administer in slow, it is not going to work properly. And administer the drug via central line only. There is no such limitations. Administered rapid via IV push followed by rapid saline flush. Yes, this is the very correct technique. And place the patient in the left lateral position immediately after the injection. No. Right? So C is the correct answer. Now we will go to the next question. A 65 years old male with a history of ventricular tachycardia is on IV amiodarone infusion in the CCU. 1 hour into the infusion, the patient reports pain, redness and swelling in the IV site. What is the priority nursing intervention? What is the priority nursing intervention? Yes. Now again, give me the answer so effectively. Yes. Very good. Many people have started answering correctly. The most important additional point which you have to note in while talking about amiodarone is it is an vesicant drug. It is an vesicant drug. What is meant by vesicant drug is it causes increased phlebitis, it causes increased risk of phlebitis. Hurry yaar. Okay, and it causes increased risk of tissue necrosis also. Okay, tissue necrosis also. Okay, so it is an vesicant drug which causes increased phlebitis and necrosis because the pH of the drug is quite high. Okay, sorry, quite low. So that's why what happened when when you have to stop the infusion, because the patient is having pain, redness and swelling, which is telling that the patient is going for any extravasation. What is meant by extravasation? Anybody? Anybody tell me what is extravasation? Extravasation is like when you administer a drug in the IV, and if the drug is leaking to the nearby tissues and structures, that is termed as extravasation, right? And this particular amiodarone has the increased risk of extravasation. And what happens? It irritates the vein and it will leak inside the surrounding tissue. That is termed as extravasation, and it causes severe flushing and redness and pain and swelling in that particular area. So if the patient reports such things, you have to stop the infusion and assess the extravasation. Apply warm compression and elevate the arm. It is going to worsen the symptoms. Slow down the infusion rate. No, it is not going to work. Never ever slow down the infusions of amiodarone, because it is again going to cause necrosis also. Right. Flush the IV site with 0.9% NS to dilute the drug. No, this is also incorrect. So next, okay. So a 78 years old female with atrial fibrillation and heart failure is on digoxin therapy. Today she reports nausea, fatigue and blurred vision, and with yellow-green halos. Her pulse is 48 beats per minute and irregular. What is the most appropriate immediate action? Come on, answer me quickly. Yes, I'm waiting for your answers. Very good. Obviously, the patient is exhibiting the symptoms of digoxin toxicity. The patient is exhibiting the symptoms of digoxin toxicity, and the pulse rate is also reduced. So you have to withhold the next dose of drug and notify the physician. And reassure the patient and administer the antiemetic. No. Encourage oral fluids. No. Prepare the digoxin reloading as bradycardia is therapeutic. No. A patient receiving haloperidol and erythromycin suddenly develop NORCET D points on cardiac monitoring. The patient is conscious but dizzy and hypotensive with pulse of 52 beats per minute. The ECG shows polymorphic ventricular tachycardia with QT prolongation. What is the nurse priority action? Yes. Come on, now tell me what is the answer. I'm waiting for the answer. Kindly answer in the chat box. Okay. A patient is receiving haloperidol and erythromycin, suddenly developed NORCET D points on cardiac monitoring, and the patient conscious but dizzy and hypotensive with a pulse of 52 beats per minute. ECG shows polymorphic ventricular tachycardia with QT prolongation. Which of the following is the nurse priority action? Very good. Yes. Obviously, at the end, they are trying the patient as a case of NORCET D points. Okay, so ultimately the drug of choice is your magnesium sulfate, and you're going to administer it. Start the CPR and prepare for defibrillation. No. Stop the monitor and check manually for the pulse deficit. No. Call the physician and wait for further instruction. No. So here you have a keyword, as prescribed, right? Which means it is understood like already they have been prescribed this particular medication and the patient is on NORCET D points. So you're going to administer the particular drug. Next question. A 45 years old male with SVT receives 6 mg IV adenosine push, and immediately after administration he becomes unresponsive and pulseless. The cardiac monitor shows a flat line, that is asystole, for 5 seconds before spontaneous rhythm returns. So which is the nurse's best action? See, here in actual examination, they won't give these things. To make you understand in the MCQ point of view, I made this MCQs, right? So in actual examination, they won't give you what is that particular rhythm and all, right? Now tell me what is the answer. A 45 years old male with SVT receives 6 mg IV adenosine push, and immediately after administration, he becomes unresponsive and pulseless. So the cardiac monitor shows a flat line for 5 seconds before spontaneous rhythm returns. What is the nurse best action? Some people are answering B. A. No. See, the patient, okay, the patient will become pulseless, okay, after administration of adenosine. After rapid administration of adenosine, as I said you, in the cardiac monitor, you will see a systole for 5 seconds. Okay, then only the rhythm will recorrect and it will come. Okay, the spontaneous rhythm will rise. So you have to tell, okay, and you have to tell, continue monitoring and reassure the family this is expected. This is the expected finding. And they are telling, see, for 5 seconds the patient was in asystole, but before the spontaneous rhythm returns, which means the spontaneous rhythm has been returned after administration of adenosine. So what the question is trying to tell, which means the patient is reverted. So you have to instruct the patient, that is continuous monitoring, and you have to reassure the family that it is a normal finding. An elderly female on digoxin present with confusion, vision changes and heart rate 38 beats per minute. Her ECG shows second degree AV block, okay, that is Mobitz type 1. Digoxin level is 2.4 Ng per ml. What is the best clinical judgment? Now tell me. Waiting for the answers. An elderly female on digoxin present with confusion, vision changes and heart rate is 38 beats per minute, and the ECG shows second degree AV block. Mobitz type 1. Digoxin is 2.4 Ng per ml. So what is the best clinical judgment in this point? Very good. People started answering correctly. Very good. Priya, Priyanka, Maina, Meghna, Megha, Muva, Dibesh, Kunjan, Dharmaraj, Pramod, Suchitra. Very good. B is you have to withhold the digoxin and monitor the potassium. Like for example, confusion, vision changes and the heart rate is 38 beats per minute and the patient is going for second degree AV block. If the patient is going for second degree AV block, like AV block is digoxin toxicity is one of the important cause of showing AV block. Okay, digoxin toxicity is the cause of atrioventricular block, that is heart block. Okay, it is one of the causative factor of heart block. And you have to note the most important digoxin level. What is the therapeutic digoxin level? The therapeutic digoxin level is, okay, very important point to note. It is 0.5 to 0.9 Ng per dl. It is Ng per dl, not Mg per dl. Okay, the normal therapeutic level of digoxin is 0.5 to 0.9 Ng per dl. When this particular drug is going more than 0.9 also, there is a risk of toxicity. But we claim it is going to toxicity when it is greater than 2 Ng per dl. So obviously the rate is more than 2 Ng per dl, so the patient is going for digoxin toxicity, which in turn cause the patient to get your Mobitz type 1 heart failure. That is, what is the ECG findings of Mobitz type 1 heart failure? Anybody? ECG findings? Anybody? Already the class is over. See, standard books, updated books are telling it is 0.5 to 0.9 Mg, but Ng per dl. But if at all you have the options in these variants, you can click it, right? Yes. Now tell me, what is the ECG findings of Mobitz type 1? PR prolongation, only PR prolongation. See, PR prolongation is first degree heart block. ECG findings of Mobitz 1, okay, that is the second degree, is progressive prolongation. Very, very important to note. Progressive prolongation of the PR interval. Progressive prolongation of PR interval. Very, very important point to note. Never ever forget. Mobitz type 1 is prolongation of the PR interval. The normal PR interval is 0.122 to 0.20 seconds. Okay, 0.1 to 0.20 seconds. Okay, very good. There will be drop in QRS also. Now tell me, a patient on sotalol develops torsade D points, IV magnesium sulfate 2 mg is administered, but the rhythm persists with decreasing BP and GCS. So what is the next best nursing priority? No. See, listen. The answer for this question is, the priority when comparing to your withholding digoxin and monitoring potassium will be administering digoxin immune fab. See, there is a confusion here. Digoxin immune fab is your digibind. Okay. See, this is not the correct answer. Withholding the digoxin and monitoring the potassium level is not the correct answer. The correct answer is, you have to give the antidote as per the, you have to give the antidote, that is your digibind. Okay. So next we have, a patient on sotalol develops torsade D points, IV magnesium sulfate 2 gram is administered. Okay. And but the rhythm persists with decreasing BP and GCS. What is the next best nursing priority? Now tell me. Very good, Akash, it is progressive prolongation of the PR interval. Yes, very good. Now tell me, the patient is on sotalol, develops torsade D points, IV magnesium sulfate has been administered, but the rhythm persists with decreased BP and GCS. Whenever you see a term of decreased BP and GCS, torsade D points is a very risky rhythm which is going to lead the patient to VT or VF. So obviously, what is the management? The management is to start the defibrillation immediately. To start the defibrillation immediately. So that will be the correct answer, right? Because the patient is going for unconsciousness and the BP is also dropping, which means the patient is going unconscious. So that means the patient is going for VT or VF. So it is definitely, you have to start the defibrillation. In case of VT and VF, when the rhythm is irregularly irregular, right? So here in this case, you cannot administer synchronized cardioversion. Why? Because R wave, the cardioversion cannot able to identify what is R wave, what is Q wave, nothing. It is a common sense. So that's why you are going to give an asynchronized defibrillation to those particular patient to revert the patient immediately. Okay, very good. So next, which anti-arrhythmic drug is known to cause pulmonary fibrosis? Now tell me, which anti-arrhythmic drug is going to cause pulmonary fibrosis? Yes, answers please. Very good, it is amiodarone. As we have discussed earlier, potassium channel blockers makes liver and skin toxic. So P stands for pulmonary fibrosis, the first and foremost signs and symptom of side effect of your anti-arrhythmic drug, that is pulmonary. Now tell me, what is the most common early signs of digoxin toxicity? You know what are the signs of digoxin toxicity? But here you have to know what is the most common early sign of digoxin toxicity. Early sign of digoxin toxicity. Now tell me. What is the early sign of digoxin toxicity? Obviously the patient will be having visual disturbance, and what is the correct answer? Yes. The most common early signs of digoxin toxicity is nausea and vomiting. GI symptoms is the first and most important symptoms you have to note, because that arises first in case of digoxin toxicity. This is all about today's session. I hope I have given a good insight about anti-arrhythmic drugs and made you clear with some concepts. Okay, so here we come to the end of the session. If you have any queries, you can connect with me through my social media handle. And thanks for watching. I request you all to share the feedbacks in the chat box or comment box. Okay, and thank you so much for watching. And thank you so much for the people who were with me from the beginning to the end, so that you got what you actually want, right? Thank you so much, Priya. Thank you. Okay, fine. Bye bye.